Is it fine, Saidulu? Now,
Yes, sir.
just see if you can see my screen. So, hi everyone. Should we start? Saidulu, just give me a thumbs up when I should start. Do we start or do we wait for others?
You can start, sir.
Okay. So, hi dear students. This is Dr. Vivek Goel, your nephrology faculty at Doc Tutorials. And this is basically a residency orientation program. And this is basically to discuss how we at the residency program are going to orient you guys. And this is mainly for for the MD and the MD medicine and the DNB medicine residents, of course. Also for the pediatric ones who are listening to me. So what is very, very important to understand is the urine analysis. See, my dear students, urine analysis is very, very close to a nephrologist's heart. Okay, because it is very, very important. And that is why it is even known as a poor man's renal biopsy. Because if due to any reason one cannot biopsy the kidney of a patient, one relies on the urine analysis and tries to judge what could be the pathology like. So with this introduction, maybe and I mean, if students can hear me, are they will they be able to at least chat with me online? If yes, then they can at least I can see some participants there. I can see some participants. Yeah, there are a few participants, and you all can chat if you all want to. Most you all are most welcome to chat if you all want to. Okay. Yeah. So without any much ado, I would like to proceed. Just a moment. Yeah. So now So I would like to begin my presentation with a quote from Sir Robert Grieve Hutchinson that the ghosts of dead patients that haunt us do not ask do not ask us why we did not employ the latest fad of clinical investigation. They ask us why did you not test my urine? Such is the importance of a urine routine examination. As I told you, it is also known as a poor man's renal biopsy. Now, starting from the very basics, how do we obtain a urine specimen? Now, there are multiple ways. One could, of course, be a spontaneous voiding, where a person is voiding the urine by himself, which is true for most of the patients. Suprapubic aspiration. Now, of course, suprapubic aspiration is only in those who do have maybe an outflow tract obstruction, or who do not are able to give you the urine sample by the traditional method. So that is it is a gold standard for urinary tract infection. It is absolutely sterile, and it does not contain any leukocytes, not even one. And a catheter. Now, this is very, very important in a hospitalized setting, because I always tell my ward nurses and the brothers that, even most of them do not know how to collect urine out of from a catheter. Because if you do not collect the urine in the correct way, you may erroneously get a false positive infection. Now, what is that? How do you collect urine from a catheter, from an indwelling catheter? Is a catheter in and out technique. So basically, you could basically insert a catheter, just collect the urine in a sterile way, of course, and take out the catheter. If that is possible, that would be the best way. If there is an indwelling catheter already, then what? You should never collect the urine from the urobag. That is the gold standard. That is a dictum. You should never collect urine from the urobag. Always disconnect the urobag and collect the fresh flowing urine from the Foley's. Always collect the fresh urine, and never from the euro bag. This has to be this is the basic that you've got to understand. Now, what are the sample types? Now, of course, we all know that the best urine sample is the early morning, midstream, clearly clean cat sample. We all know. But it is often asked in the MCQs also, that for microscopy, we prefer a second sample. Though some guidelines do say that the first voided midstream urine sample by a clean catch method is for the routine microscopy, but there are some flaws in it. So many of the guidelines, they recommend they recommend the second sample for microscopy. Why? I will tell you. And the first sample is for the proteinuria quantification, if we want to do the proteinuria quantification by a spot urine sample. A random sample could be used for a dipstick, and 24-hour urinary sample are for the quantitative studies, be it the proteinuria, be it the albuminuria, or 24-hour urinary metanephrine or cortisol. Now, as I told you, that a midstream sample of the first morning urine was recommended by some international guidelines, because it is very, very concentrated and very good for the preservation of particles. But because it was present for such a long time in the bladder, there may be lysis of the cells and casts. So you may not be able to see RBC cast, or say a eosinophil cast in the first bodied urine sample. For that is reason, we always prefer collecting the second morning urine, of course, the midstream urine of the second urine sample, which is very, very important. Now, how do we handle the urine sample? See, I'm going from the basics. This is for the medicine residents and for the people who are absolutely new to medicine, because if you do not know the correct thing, how will you educate your patients? So if it is, of course, the first or the second urine sample after 8 hours of recumbency, there must at least be 8 hours storage time in the bladder. It is more concentrated, allows for bacterial growth, useful for culture, and casts are well preserved in the acidic environment. Now, from the collection, it must be analyzed within 2 to 4 hours, because otherwise there will be cellular lysis and precipitation of solutes. Now, this is one of the very common reasons why you do not get cells and casts in the urine samples that you get in government colleges or maybe private hospitals also. The reason being, most of the urine samples seen are not spun within 2 to 4 hours. They are collected, and only when the handler is available, or the machine is they have adequate samples, do they centrifuge the urine, and they put it for microscopy. If this is not possible, refrigerate the specimen between +4 to +8 degrees Celsius, because it can cause because this will assist in preservation. But there may be precipitation of phosphates or urates. Okay. Now, how do we collect the urine? For urine you must collect in a wide mouthed container, at least having a capacity of 50 to 100 ml, and for 24 hours collection, of course, which must have a capacity of 2 to 3 liters. Okay, and you must not expose directly to sunlight, and you must prevent adherence of the urine constituents. Now, just a minute. There is. Yeah, I'm sorry for the hit. Actually, I was feeling very hot despite the AC being on. So I just switched on the fan. So what are the interfering factors? Volume intake or diuresis or fasting has a bearing on the urine because it changes the specific gravity, changes the pH of the urine. I'll tell you how. A postprandial sample could lead to a false positive glycosuria in the urine. Exercise could cause proteinuria or even hematuria in the urine. That is why we always ask the patient to avoid strenuous exercise, even sexual activity before the before giving the urine sample. Sexual intercourse is better to be avoided a day before the urine sample. And incubation time in the bladder, as I've already told you, there must at least be 4 hours of incubation in the bladder to get it accustomed to the bladder milieu. Now, how do you collect in a male? Of course, you retract the foreskin, wash it with water, no soaps or antiseptics are required, and you give the midstream urine sample, which is very, very important. For a female, you retract the labia, you wash it with water to clear the vaginal secretions. Again, no soaps or antiseptic solutions, which is very, very important. And you avoid it during the menstrual phase, which is again very, very important. Now, what are the types of analysis that you do in the urine that you collect, which is very, very important? One is a physical examination, then you do the chemical examination, and you do the microscopic analysis, which we will study in these three headings and try to understand the urine routine examination. Now, what are the components of physical examination of urine? Of course, the volume of the urine. If the volume of the urine is less than 100 ml per day, that is known as anuria. If it is less than 400 ml per day, it is known as oliguria. And if it is more than 3 liters per day, it is known as polyuria. So these are basic things which you must know. Coming to other physical aspects, what you see first is the color of the urine. What you smell is the odor. The urine pH and the specific gravity, these are the physical attributes of urine. Now, how do you examine each one of them, and what is the importance of each in practical purposes for a medicine resident, for a budding physician? That I will tell you. Now, coming to the color of the urine, so there are all the possibilities of the color of the urine that you could be having, but a clear urine or a straw colored urine looks something like this. This is, of course, a cloudy urine. So cloudy urine, of course, you could be seeing it in your wards daily. This is a very non-specific finding, to be very honest, but this could be due to even maybe an acute tubular necrosis where it is very, very concentrated. A cloudy urine could be due to a urinary tract infection as well. So a cloudy urine, of course, could be due to dehydration. This is very, very important, and it is an important sign for the physician that there could be certain renal abnormalities in this patient. Now, hematuria. Hematuria, of course, it could be ranging from absolutely bright red color of the urine, where there is frank passage of blood in the urine, to cola colored urine, where there is actually microscopic hematuria. So it could be a wide gamut of the urinary color in hematuria. Now, see rhabdomyolysis, again, due to the passage of the heme here, there could be a cola colored urine or a reddish urine. Rifampicin, we all know it gives an orange tinge to the urine. So whenever we give rifampicin to a patient, we always say that do not be afraid. Your urine could be orange colored. Now, phenol poisoning could lead to this greenish blue color, and the yellow phosphorus, of course, gives rise to this yellow color of the urine, which, of course, are not that common. But yes, you've got to understand. Now, very recently, I did give to a patient of shock, almost to a patient of refractory shock. He was in vasoplegic shock. So I gave him an injection methylene blue, and this was the very first time that I saw his urine turning dark blue. So I did see it myself. I only read it in books, but when I gave it to the patient myself, I did see this. So methylene blue is one of the options for refractory shock. So when we use this, it did turn the urine blue. So that is again one of the practical learnings that I got. Chyluria, we very often see this is a milky white urine. I have seen it in renal tuberculosis. I've seen it in renal cell cancer. Sometimes it could even be there in fungal pyelonephritis, such type of a foul smelling chyluria. And porphyria, due to the presence of porphyrins, it could lead to a reddish or a brownish urine, which is very, very important. Now, there are certain drugs that can affect the urine color, like the primaquine, the metronidazole, the nitrofurantoin, they turn the urine brownish. Out of this, nitrofurantoin is a very common drug which is used for urinary tract infections. Now, please understand, my dear students, that nitrofurantoin is used for urinary tract infections, mostly cystitis, and and cystitis itself can cause hematuria. So, whenever you give nitrofurantoin to a patient and the patient comes and tells you that, sir, my urine is getting brownish in color, sometimes it could be difficult that whether it is due to hematuria or whether it is due to nitrofurantoin. So, you've got to, interpret it with a clinical eye, and you've got to understand how much is the importance in clinical practice of that patient. Now, apart from this, indomethacin, triamtrene, methylene blue turns it blue or green, as I've already said. Rifampicin, warfarin, phenazopyridine dyes, and sulfasalazine may cause it orangish in color, which is again very, very important. And alkaptonuria, as you know, it's a genetic condition, can cause a urine black on standing. Now, odor. Odor, of course, is I do know that it is more of a theoretical interest, because none of us are so interested in today's 21st century that one would go to smell the urine and diagnose the condition. But very, very importantly, the a bad smelling urine, that is abnormal urine odor, is very commonly caused by urinary infection, because it is due to the presence of ammonia produced by the bacteria. So whenever a patient tells you, sir, my urine is smelling very bad, especially very many female patients will come and tell you that, sir, my urine has recently started to smell very, very bad, always do a urine routine and culture, and you will get a lot of pyuria, and you will get a bacterial growth in that patient. That is very, very important. So infection. Apart from that, ketonuria, fruity odor, maple syrup urine disease is a maple syrup odor, phenylketonuria is a mousy odor, isoveric acidemia is a sweaty feet odor, and hypermethylaemia is a fishy odor. So this is more for theoretical interest. Coming for urine pH. Now, urine pH is always given in the routine urine examination, but most of us fail to see that or fail to understand that. Now, please understand, why is urine pH important. Usually, the urine pH ranges from 4.5 to 7.8. Now, when is a low pH seen? Low pH is seen when the patient has metabolic acidosis, when the patient consumes high protein meals, and in volume depletion, because in volume depletion, aldosterone is stimulated. Aldosterone stimulation causes acid excretion in the urine, and it causes alkalosis in the body, and that is why there is an acidic urine. So for acidic urine, always remember, if there is a metabolic acidosis in the body, so there will be more of acid excretion in the urine. If there is hyperaldosteronism, which could be due to dehydration, or even a physiological cause like a high protein meal, can cause a acidic urine or a low pH urine. Now, low urine pH may help you in distinguishing a prerenal AKI from ATN, because an ATN is usually associated with a higher pH, whereas pre-renal AKI is associated with a lower pH, as I told you, due to increased aldosterone production in the body. I hope this is clear to you. Coming to specific gravity. Now, specific gravity we've all studied in physics. In basic sense, it is the weight of something to an compared to an equal volume of water. Now, it is measured by refractometry and dry chemistry. Now, refractometry measures the specific gravity using the refractive index of the solution. So, it requires only one drop of urine. Refractometry actually requires only one drop of urine. Please understand, this is very, very important. Now, specific gravity, it is affected by protein, it is affected by mannitol, dextrans, or radiographic contrast media. That is why if a patient has undergone a recent contrast CT scan or a contrast angiography, the patient has received iodinated contrast media, and that will alter the urinary specific gravity. Because the urine specific gravity is increased disproportionately to the osmolality, it will suggest a highly concentrated urine. So that is very, very important. Now, this was about the physical analysis. Coming to the chemical analysis. Now, first thing is first, that is glucose. We all know in our first year biochemistry classes, we have done this Benedict's test, where we took 5 ml of Benedict's reagent, 8 drops of urine, we boiled it over a flame for 2 minutes and let the solution cool down. Have we or have we done not? And when we saw the color change, we know that glucose was present in the urine because it was the reducing substance. So this is very, very important, the Benedict's reagent or the Benedict's test. But of course, today we will not do this. We have, and this was of course the basis of color. On the basis of color change, we would say that what amount of reducing sugar is present in the urine. But now, of course, we have a chemical test which is impregnated in the dipstick urine sample. What we do is it uses the oxidase peroxidase activity, and there is a chemical reaction. And depending upon the amount of sugar present, the dipstick will tell us it is trace positive, 2 plus, 3 plus, or 4 plus, which is very, very important. Now, what the urinary glucose detection, why is it important? Because it can be present in diabetes mellitus. It could be due to renal glycosuria, even with a patient of normal renal function, where a blood glucose of more than 80 causes spillage of the glucose in the kidney, in the urine, and that causes renal glycosuria. In today's day and age, in every diabetic patient, you will find urinary glucose 3 plus. The reason being they are on a drug known as SGLT2 inhibitor, the dapagliflozin, the empagliflozin, or the canagliflozin, all of which inhibits the sodium glucose transporter 2 in the proximal tubule, which causes glycosuria. So glycosuria, whenever you see in a diabetic patient, there are two DDs. Number one, uncontrolled diabetes. So always see the sugar levels of the patient. If they are fine, if they are high, it means you need to add insulin, you need to add higher drugs. But if the sugar is fine, HbA1c is controlled, and you see glycosuria, you know what the patient is on. The patient is on SGLT2 inhibitors. But understand that this test only detects glucose and not other sugars, which is very, very important. Now, protein. Similarly, the Benedict's test for the glucose, you have the heat coagulation test of the protein, where we would heat over the Bunsen burner in the first year biochemistry. But of course, we don't do it now. Now, another test which we all have done is the sulfosilicic acid test. Sulfosilicic acid test is for the all types of protein in the urine, that is the albumin and the non-albumin, which we have done in our first year test, which is often asked. But now, in today's day and age, the urinary albumin is measured by the immunoturbidometric method, double antibody radioimmunoassay, nephrometry, and size exclusion HPLC. So this is very, very important. These are the modern methods, the immunoturbidometric method. So there is immunology involved here, and the radioimmunoassay. So these are These methods, please remember these names. These are the methods which actually, if to simplify, they use an antibody against the albumin, and that is specific to albumin, and hence they detect the urinary albumin. Now, coming to the dipstick test. Now, the dipstick test for a protein are semi-quantitative because there is a pH sensitive colorimetric indicator that changes the color when the protein binds to it, because you know that a protein is a negatively charged substance. So it is semi-quantitative and it is a pH sensitive colorimetric indicator. But understand that it is only sensitive to albumin, and and it does not detect non-albuminuric proteinuria. So other proteins like other than albumin, like the Tam-Horsfall protein, like the Benz-Jones protein, they are not detected by your dipstick protein estimation, which is very, very important. I hope I am clear to all of you. Now, please understand a fallacy about dipstick test, that a false positive albuminuria can be shown if their urine is very concentrated. So whenever the specific gravity is high, you can get a false positive urinary albumin plus. So please, students, make it a habit. Whenever you see urinary albumin plus or plus plus plus, always see the specific gravity. The specific gravity, if it is 1010 or 1015, it is fine. But if the specific gravity is 1025 or 1030, that is on the higher side, always understand that this is a false positive albuminuria due to highly concentrated urine, which we very often see in acute tubular necrosis or other dehydration conditions. Am I clear? Now, what are the proteins in normal urine? You know that 20% of the proteinuria, up to 30 milligram per day, is constituted by albumin. 50%, that is 75 mg per day, could be your Tam-Horsfall protein or uromodulin. Others are immunoglobulin, secretory IgA, and your urokinase. So these are the normal proteins in the urine. So to say, the normal maximal protein excretion in an adult is 150 milligram per day, out of which 75 mg is Tam-Horsfall and less than 30 is albumin. And the rest minimal portions are formed by other proteins. So this is the normal physiological protein excretion in an adult. Now, this is basically the types of proteinuria. So the types of proteinuria are glomerular, tubular, overflow, and post-renal. Now, glomerular proteinuria occurs due to increased glomerular filtration, the chief protein being albumin, and usually the amount is moderate to high, so more than 2 grams per day. Most common cause is glomerulonephritis. The tubular proteinuria occurs due to decreased tubular reabsorption, and the types are Tam-Horsfall protein and beta-2 microglobulin. Again, this is of milder variety, so it leads to less than 2 gram per day. Overflow proteinuria is due to increased production of low molecular weight proteins. That is due to Benz-Jones protein. And they can be less than 2 gram per day or even can be more than 2 gram per day. But the post-renal proteinuria is due to inflammation in the urinary tract. And this, the example is due to the urinary tract infection or urinary tract inflammation. And this is constituted by IgG or the IgA, which is seen in the urinary tract infection very, very common. So these are the basically the types of proteinuria according to the pathomechanisms. So this is not that important, more of a theoretical thing. Now, tests for protein. We studied some specific tests for detecting albumin in the urine. That is the colorimetric method, the immunoturbidometric method, the nephelometry, HPLC. That was fine. But usually, what are the tests for protein excretion in the urine? Number one, what we do is a dipstick test, which could be done on a random urine or a morning sample. Second is for the quantification, we do a 24-hour urinary protein estimation. And a surrogate of 24-hour urinary protein is the protein creatinine ratio on a random sample. So this is basically a quantification methods. And this is of course semi-quantitative. So you will get 1 plus, 2 plus, 3 plus or trace, whatever. Am I clear? If you ask me what is the gold standard for measurement of urinary protein, and that for that there is no prize at all, because that is very, very easy. You collect the 24-hour urinary sample and estimate the protein out of it. That would be the best method. Now, dipstick, again, it is a pH sensitive colorimetric indicator. The indicator name is often asked, that is tetrabromophenol blue, and which we have already discussed. It is very, very sensitive to albumin. So this is the chemical reaction, and depending upon the amount of protein, it could show 1 plus, 2 plus, 3 plus, or 4 plus. Now, 24-hour urinary protein excretion, as I said, why is it the gold standard? Because it is gold standard because it averages the variation in circadian rhythm, because you know that your protein excretion also can vary by from day to night, depending upon your posture, depending upon the various sympathetic surge. There is even something known as orthostatic proteinuria, which we will discuss in the future classes. And that is why it is an average of the circadian rhythm, and it quantifies the total protein rather than only the albumin. So that is why it is the gold standard, and we often resort to this method whenever there is any doubt. But let me tell you, students, what happens is this is a cumbersome thing, because you've got to tell the patient that, say, from morning 8 a.m. today to morning 8 a.m. tomorrow, whichever urine you void, starting from the first urine today and the first urine tomorrow, always void in the urinary container. Now, these things are easier said than done. This is a bit difficult because the patient might be working, the patient might be going somewhere, patient might not be home all the time to be doing this. So, it could be difficult. That is why we use a surrogate method, that is spot urinary protein creatinine ratio or spot urinary albumin creatinine ratio. As I was telling you, the spot urinary PCR. So this is an alternative, but the limitation is if the patient is of large muscle mass, it can underestimate, and if the patient is cachectic, it can overestimate urinary protein creatinine ratio. But always understand that you've got to estimate the adequacy of the sample. So how will you know that whichever sample the patient gave, that spot sample, it was adequate or not? So you've got to see the creatinine excretion in the sample. For a male, the creatinine excretion should be, for a 50 above male, it could be 15 to 20 mg per kg per day. But for a female, it should be 10 to 15 mg per kg per day. For under 50 males, it should be 18.5 to 25 and 15 to 20 mg per kg per day for female. So let me simplify life for you. So for a male, you can just remember 15 to 20 mg per kg per day. And for a female, 10 to 15 mg per kg per day. Now, for example, if there is a 60 kg male, the patient should be having at least 1200 milligram per day of creatinine in the urine. If it's a 60 kg female, the patient must be having somewhere around 800 to 900 mg of creatinine in the urine. If not, then if it's a protein creatinine ratio. So if the denominator is only wrong, the ratio becomes wrong. So always check the adequacy of the sample by this denominator value, which is the creatinine excretion in the urine, which is very, very important, my students. Now, urine ACR versus urine PCR. Now, please understand, ACR cannot be derived from PCR and vice versa. As the name implies, this only has the albumin, and protein creatinine ratio has albumin plus other proteins. So the name says it all. But please remember, the ACR has been recommended by a number of guidelines because of an improved ability to standardize albumin versus total protein, because albumin is usually the predominant protein lost in the urine. So in whichever diseases you feel that it is predominantly an albuminuric condition, say diabetic kidney disease, always do a ACR. But ACR is not superior to PCR in detecting CKD in non-diabetic subjects. So if it's a non-diabetic patient, or if you suspect a non-selective proteinuria, say an FSGS patient, a membranous nephropathy patient, always do a urine PCR. I hope this is clear to all of you. Now, this is, the KDIGO categories of proteinuria, the mildly increased, moderately increased, severely increased, A1, A2, A3. And these are the details which you already know of. So I'm not going into much of the details. Now, in the chemical analysis, next would be ketone estimation in the urine. So we've already done this test, Rothera test in our first year biochemistry, where we would see the purple ring for the ketones. But now what we do is the nitroprusside acts with the ketone, that is the acetoacetic acid, and forms a colored complex. So it is basically the nitroprusside reaction that occurs in the dipstick test. And depending upon the ketone concentration, it gives a color change. But always remember that there are certain limitations for urine ketone detection. That is, it could be present in diabetic ketoacidosis. It could be present in prolonged fasting, because fasting causes ketonemia and ketonuria. But very, very important that the urine ketone estimation only measures acetoacetate and acetone, but misses beta hydroxybutyrate. So if there is beta hydroxybutyrate, you may get a urine ketone negative. So to say that a negative urine ketone does not mean no ketoacidosis. This is the take-home message from this slide, which is very, very important. I hope I'm clear to all of you. So urine ketone, it is a bedside test which we do for any patient in the emergency who's come with a very high blood sugar. There could be acidosis, and you check immediately for urine ketone and confirm whether there is ketoacidosis or not. Now, very, very important, blood. Blood in the urine, there is a peroxidase activity of the heme moiety. In, say, hemoglobin is made up of heme and globin. The heme moiety has a peroxidase activity, and that is used for a reaction between a peroxide and a chromogen, which gives a colored product. Now, negative results, which are false negative, are uncommon, but may be caused by ascorbic acid, which is a strong reducing agent. And false positive may be given because of oxidizing contaminants like a povidone iodine. It could be a semen, a high concentration of bacteria with pseudoperoxidase activity like Enterobacteriaceae, Staphylococcus, and Streptococcus species. And that is why, my students, very commonly a urinary tract infection sample of urine with Enterobacteriaceae, you will get blood to be 2 plus or 3 plus. Now, there are two things to it. A UTI could cause hematuria, and it can even cause a false positive reaction in the dipstick. So it's very, very difficult to know unless on microscopy you see RBCs in the urine, which is very, very important. Now, also remember, a dipstick test positive for hemoglobin, in the absence of RBCs in the urine sediment, as I told you, it could either mean there is hemolysis or there is rhabdomyolysis. So please understand that basically you need the hem moiety for this test to be positive. That head hem could even come from the myoglobin pigment of the muscle. If there is rhabdomyolysis also, it will lead to a positive urine dipstick test. This is the test which I've already told you. So false positive could be there in dehydration, exercise, hemoglobinuria, myoglobinuria, and a false negative could be there due to very acidic pH, elevated specific gravity, proteinuria, and vitamin C, as I already told you, that is ascorbic acid. Very, very important. Now, leukocyte esterase, again, which is again very, very important, that leukocyte esterase is a test that detects pyuria and it does not detect bacteriuria. Please remember this sentence, that leukocyte esterase detects pyuria and not bacteriuria. Okay. So this is the chemical reaction that takes place in the detection of leukocyte esterase test. And it could be present in any pyuric condition, which could even be, a non a sterile cause of sterile pyuria. For example, a renal calculus, an acute inflammation, an acute interstitial nephritis, even in acute glomerulonephritis, you could get a leukocyte esterase positivity. Limitations could be oxidizing agent, menstrual contamination. So again, this is very, very important. Now, nitrites. Now, nitrites actually here, it actually uses the basically the presence of nitrate reducing bacteria. So what happens here is that the nitrite reacts with the arsenalic acid to form a diazonium compound, which further reacts with another chromogen to form a pink colored endpoint. Okay. So basically, there are certain bacteria that reduce the nitrates and cause and form nitrites that react with the chromogen to form a colored product. So this actually, it detects bacteria presence which are nitrate reducing, unlike leukocyte esterase test. So there could be false negative results due to prolonged sample storage. And please remember, it takes up to 4 hours to convert nitrate to nitrite. That is why I told you that a bladder incubation time of 4 hours is very, very important to give a true positive nitrite test. Otherwise, you will get a false negative nitrite test. Now, bilirubin. We all know that bilirubin is present in the urine in obstructive jaundice or in hepatic jaundice, not in the prehepatic or your hemolytic jaundice, because the unconjugated bilirubin, which is always combined with the albumin, is does not present in the urine. And here bilirubin combines with a diazo salt, which forming the azobilirubin, and then it gives a color change. So these are the fallacies which I have already discussed with you guys. What gives a false positive and what gives a false negative. What is very, very important for you guys is to remember the fallacies of hemoglobin presence, albumin presence, nitrite presence. This will be very, very, commonly tested with you in your clinical practice, where you will be getting a lot of patients coming to you with urine reports. Next is the urine microscopy. So for next is the urine microscopy. Now, urine microscopy is one very, very favorite topic of all the examiners. If even for your MD final examination, if a old examiner comes to you who had good interest in nephrology, he could start a case of nephrotic syndrome by asking, how do you do a urine microscopy? So, if you will be absolutely stunned if you have never attended your pathology labs and you've never seen a urine sample being spun. So you've got to see this to know this. Otherwise, if you mug it up, you will always forget. So basically, we take around 10 ml of urine, which is centrifuged at 2000 RPM for 5 minutes. And a defined volume of supernatant is removed by the suction, and the pellet is resuspended by gentle agitation. Then a drop of urine is placed on a slide, a cover slip is placed, and then you see the urine under a microscope, first in low power, then in high power, and then, if possible, by a phase contrast microscope. But usually that is not available everywhere. So this is very, very important. Now, hematuria. So you know that hematuria is presence of more than equal to 3 RBCs per high power field. For glomerular hematuria to be present, we know the rule of 40 and 5. There must at least be 40% dysmorphic RBCs and more than 5% acanthocytes and 1% RBC cast. So 40-5-1 rule, there must be 40% dysmorphic RBCs, 5% acanthocyte, and 1% RBC cast. This is very often asked in MCQ as well. Now, coming to leukocyturia or pyuria. Now, if there is a presence of more than equal to 5 pus cells in the urine per high power field, only then is pyuria significant. Whenever you get pyuria, always try to understand that pyuria could be due to infective causes, could be due to non-infective causes. Now, always there are very many patients, especially CKD patients, who are very used to seeing their own urine report. And whenever they see pus cells in the urine, say 10 cells, pus 10, 12, they always call up and tell you, hey doc, I have an infection in the urine. And you ask them, how do you get to know? Then they say, sir, there are 15 pus cells in my urine. There are 10 pus cells in my urine. Do you have any symptoms? No, sir. Is your urine culture positive? No, sir. So first of all, you have to understand that all pyuria is not urinary infection. One of the causes of pyuria is infective, but there are many causes of non-infective pyuria, like acute interstitial nephritis, like renal calculus disease, like acute glomerulonephritis that could lead to pyuria, more than 5 WBCs in the urine. But infective causes, of course, there could be bacterial infections, there could be tuberculosis infection, fungal infection. All these will lead to infective pyuria. Now, eosinophils. There could be eosinophiluria present in the urine, which is detectable with a Hansel or a Wright stain, which is typically seen in interstitial nephritis, in cholesterol embolism, in glomerulonephritis, and even in prostatitis. This we've already mentioned and discussed in details. So these are the typical dysmorphic RBCs that you see are very, very important. And these are your acanthocytes, which is typically seen in glomerular hematuria. Coming to leukocytes, the neutrophils are very predominant, and they could even be seen as moving refractile granules in cytoplasm of neutrophil. Hence, they are even called as glitter cells. Pyuria, as I've already mentioned, it could be UTI, calculi, glomerulonephritis, interstitial nephritis. Eosinophiluria, we have already discussed. If there are more than 1% of total leukocytes are eosinophils, that is known as eosinophiluria. Now, renal tubular epithelial cells that could be shed off in the urine. It could be present in any tubulointerstitial disease. Very commonly, you find it in acute tubular necrosis. The transitional cells, that could, a lot of transitional cells, it could be shed in the urothelial cancers, even in your the urethral injury, like the ureteric stone could lead to transitional cells in the urine. Now, lipiduria is seen, of course, classically in nephrotic syndrome. It stains positive with the Sudan 3 dye, and there could be oval fat bodies in the urine. Now, coming to casts in the urine, casts again very, very important. The cellular cast could be RBC cast, WBC cast, or epithelial cast. And the acellular cast could be hyaline cast, which is very common, the most common cast. It is seen even in normal urine. It could be seen in dehydration. granular cast or the waxy brown cast. It is seen in the acute tubular necrosis. This is the muddy brown cast. Then you have the waxy cast and the fatty cast, which is seen in your nephrotic syndrome, pigment casts, and lot of crystal casts. So this is a typical hyaline cast or a benign cast. This is an RBC cast. This is a WBC cast. This is a granular cast or a muddy brown cast. This is a waxy cast. This is a renal tubular epithelial cast, where the renal tubular epithelial cells have surrounded the TAM horsal protein, which is basically the nucleus of every cast, and they form the renal tubular epithelial cast. Coming to crystals, now there are certain crystals that predominantly form in acidic urine. That is the uric acid crystal, calcium oxalate crystal, cysteine crystal, leucine crystal. Whereas in alkaline urine, you have the calcium carbonate crystal and the struite crystal or triple phosphate crystals. This is the calcium phosphate crystal, which appears like the star-like bruchite. This is the coffin lid crystal of the struite crystal. It actually occurs like a coffin lid. This is the branch of a broomstick, which is actually an amoxicillin crystal, a drug-induced crystal. Ciprofloxacin can cause a star-shaped crystal. Calcium oxalate can cause an envelope-shaped crystal, and uric acid crystals could be rhomboid or diamond-shaped. This is a cholesterol crystal, which actually appears like a knife or a dagger. Now, what are the what are the drugs that can cause crystals? It is amoxicillin, ciprofloxacin. You have the antiretroviral therapy, that is the indinavir, acyclovir, and barbiturates and the radio contrast agents. So this is a urine microscopy scoring system, which is actually to judge the urine sample, but it is not that important. It is the Chawla, you have the Chawla scoring, you have the Parzella scoring and the Backshaw scoring systems. Now, how is the urine important in a disease known as multiple myeloma? So in multiple myeloma, you could detect the monoclonal or the M protein by 24-hour urinary protein electrophoresis, where you will see an M band in the urine, or you can do a urine protein immunofixation, where you will see qualitatively that what type of the light chain, what type of the monoclonal protein is being secreted in the urine. This is the Benz-Jones protein, the test that we do, where we see that a monoclonal protein is present in the urine, which we have done in our biochemistry classes. Now, in infections, of course, we've already seen in infections, there will be pyuria, there will be pus cells in the urine. You could see bacteriuria, the bacteria in the urine sample, and you will see RBCs, that is hematuria, I have already mentioned. So in a UTI sample, always look for all the three. And there are certain microbial antigens. You could use a bedside dipstick method for certain antigens in the urine. It could be for strep pneumoniae and even for Legionella. In pregnancy, you could detect the beta HCG levels and the raise in the urine sample to diagnose pregnancy by different prega kits. And for preeclampsia, if a hypertensive woman, that is a woman with gestational hypertension, has proteinuria, which is significant, it could indicate preeclampsia. So that is again very, very important. These are the different biomarkers which could be detected in the urine that could detect AKI, and that could even detect AKI in the incipient stage where the serum urea creatinine have not risen still. That is why they are known as a novel biomarkers of AKI, like the urine NGAL, the urine interleukin 18, urine KIM1, urine LFAP, urine cystatin C, which is very, very important. In transplant, of course, you have the urinary decoy cells, which are cells with nuclear changes, which actually were detected in RCCs, but in transplant urine, it detects and it is mostly indicative of BKV nephropathy. Of BKV nephropathy. So this is an automated analyzer which is used in most of the tertiary institutes, where you put the urine and you get an automated urine report like this. So in this urine report, it reads blood 3 plus, bilirubin negative, bilirubin negative, ketone negative, glucose negative, protein negative, the pH is 6, and the specific gravity is 1.020. So it's an automated analyzer which is used in most of the good institutes in the country. Okay. Now I hope that I was a bit fast because I wanted to end it in time, and I think that I have been able to convey the very, very important message. But before I conclude, I would like to conclude it with the quote of Dr. Joel M. Toff, saying that the product of kidneys is urine is like the product of a factory is pollution. Urine is a byproduct. The product is homeostasis, which is very, very important. Okay. So with that, I would like to conclude today's session, and I'm open to questions if any. So students, if there is any questions from any participants, please let me know. I hope you understood the basic essence of the presentation. Guys, anyone who wants to ask me a question may ask. If there are no questions you want to ask me here, you could even ask me personally. So Dr. Shakti Rajagopal asks how to collect pediatric samples, sir. So, a pediatric sample would be no different. You have to collect in the very same way. But yes, a child would not be that, what to say, cooperative in telling you that, whatever the instructions you give him. So that is why 24-hour urinary samples collection in a child is very, very difficult. So better you collect the first or the second morning urine sample as you do it. Okay. I think what he also implies is that a child may not be a very small child may not even be able to tell you that he is going to pass urine now. So that again, you've got to collect it. You've got to be very, very vigilant, because it is very, very difficult sometimes to collect the urine. You are absolutely true, because unless you catheterize the patient, which of course you don't, so it is very difficult. So since there are no more questions, we would like to conclude the class here. Thank you very much for a patient hearing, and you can ask me questions. My WhatsApp number is 98309 40818. 98309 40818. So you could even WhatsApp me anytime. You could even uh, chat with me on Instagram. My Instagram ID is the_kidney doctor. I even post some informative videos there. You could even follow me there, and we could have a chat there, or you could even mail me. Thank you so much. Good night.